With that, may we invite Dr. Sushmita Shah for a talk on cornea and ocular surface in cataract surgery. Sushmita.
Good afternoon, everyone, respected chairpersons. Before I start, I'd like to thank Parthoja Monideepa ma'am for inviting me to this amazing meeting, and congratulations to the entire team on their glorious journey, and I wish them all the very best. Talk given to me was cornea and ocular surface in cataract surgery, quite a vast topic. I'll try and do my level best in 7 minutes. So start with cataract surgery in endothelial disease. As we know, the Fuchs endothelial corneal dystrophy is the predominant condition in
slides not visible.
Ocular surface in cataract surgery. Starting with cataract surgery in endothelial disease, as we know that Fuchs endothelial dystrophy is the commonest endothelial pathology that we encounter in our practice, apart from some of the other conditions like inflammatory pathologies, etc. The basic, apart from a clinical diagnosis, the basic investigations required are central corneal thickness and the endothelial cell count, both of which can be easily obtained with the help of a specular microscope. Additionally, this paper from the Mayo Clinic, which has shown certain parameters which are important to diagnose and monitor the degree of Fuchs endothelial dystrophy, and if you have access to a Scheimpflug topographer, these parameters include displacement of the thinnest point of the cornea, loss of the parallel and circular oval isopax, and a focal area of posterior surface depression, that is bowing into the anterior chamber. Now these three parameters, depending on whether you have one or all three, will decide whether you would like to go for a cataract surgery alone or a combined procedure. Now, so this is the main question that one has to answer, as to whether you should go for a cataract surgery alone or do a combined keratoplasty. This very elegant chart by Moshirfar et al., which gives us clear-cut guidelines about when you should do a combined surgery and when you should go for a cataract surgery alone. And to just briefly summarize this chart, if you have a central corneal thickness of less than 640 microns and an endothelial cell density of more than 1,000 cells per square centimeter, you can safely go ahead and do a cataract surgery. If the CCT is less than 640, that is a thinner cornea, but endothelial cell count between 500 to 1,000 cells, it is better to do, you can do a cataract surgery, but you need to explain the possible risk of endothelial decompensation post-op and the need for a possible endothelial keratoplasty post-operatively to the patient. The third variety is if the CCT is more than 640 micron, that is a thick edematous cornea, and an endothelial cell density of less than 500 cells per cubic millimeter, better to go for a combined cataract and endothelial keratoplasty. Now this is a case of where we went ahead and did a phacoemulsification alone. So as you can see here on the retroillumination, the black dots on the cornea, which are very much suggestive of the guttae. Now I have caused a small descemet membrane while at this place of the side port, so I've created a new side port. That is the safest thing to do. The soft shell technique, as described by Dr. Ashnikov, first dispersive viscoelastic to coat the endothelium, followed by cohesive viscoelastic under the dispersive viscoelastic. Keep the phaco tip as far away from the endothelium as possible. Divide the nucleus into smaller fragments so that they don't go and touch the endothelium and cause endothelial damage. And as much as possible, go for in-the-bag phacoemulsification. Avoid the nuclear fragments from running around in the AC and hitting the endothelium. And here you see the nucleus has completely been emulsified. Keep repeating the viscoelastic double soft shell. Careful implantation of IOL, and it has to be a hydrophobic acrylic IOL, because many times if the patient needs the endothelial keratoplasty in the future, hydrophobic acrylic is recommended. Washing off all the viscoelastic. So, and one more thing is the use of BSS Plus, because it has glutathione, which is again considered endothelio protective. This was another case which had advanced Fuchs, and we planned for a combined procedure. As you can see, extensive guttae. So we planned for a DMEC along with phacoemulsification. So we are peeling off the descemet membrane first, in toto, and then the phacoemulsification is done as planned. And the hydrophobic acrylic IOL has been implanted, and we constrict the pupil after that using pilocarpine. This is the DMEC scroll, which is being used, the Meles injector, and is injected into the anterior chamber. The first step is to close the wound with a 10-nylon suture, so you don't want to lose the scroll. Next, with the keeping the AC shallow. We try and open up the DMEC scroll. It's not so easy, but then Fuchs is one of the most easier cases of DMEC, and combined DMEC and phaco is the recommended surgery of choice in Fuchs. So we try to do DMECs in Fuchs if we have to do endothelial keratoplasty, end of the surgery with a nice bubble. So now the third case is a very complicated post-vitrectomy for endophthalmitis, hard cataract, non-dilating pupil, and elderly lady, endothelial cell count was less than 700, so we planned a combined procedure again. Here we have peeled off the descemet membrane, thus the B hex is being implanted into the AC, and we are trying to expand the pupil with the B hex. I should have used the forceps, I agree, but I've just used the dialer for that. So once the B hex being there, the excellent visualization and make the surgery very safe for us. Hydrophobic acrylic 3-piece IOL in the back. Now the B hex is being removed out of from the pupillary margin and is taken out of the anterior chamber. And the entire viscoelastic has to be washed off very, very meticulously. And this is the DSEC lenticule, which is placed on sheets glide over a cover of viscoelastic and is injected into the anterior chamber. We remove the sheets glide, remove the cystitome, and gently nudge the disc, donor disc away from the wound. AC is formed with BSS first and then with the air. And here we have to close the main port with single tenon nylon. Again, AC formed with first BSS and then air. And gentle ironing, and we have the donor disc well in place. So the patient did very well. Coming to other conditions like irregular astigmatism, keratoconus, vascularized corneal scars, post-radial keratotomy, and post-penetrating or anterior lamellar keratoplasty, all of which cause irregular astigmatism. Now with keratoconus, Chitra ma'am has talked very much in detail, so I need not go much. So fortunately, KC is non-progressive in the 40-plus age group, and whatever formulas, one thing is important is if you have a patient who has a topography, as in the photograph up, the results might be predictable, but you have a cornea which has advanced KC, no matter what I will put, you are bound to land up with some amount of refractive surprise. So under promise and over deliver, and better to go for such advanced cases, monofocal IOLs. Coming to corneal scar, location, depth, etiology of the scar, along with the astigmatism induced by the scar, all play a role on which decides how much is the post-op visual outcome going to be, and we need to plan surgery accordingly. If the scar is central but allows visualization, one can even do a sequential surgery, as in do a cataract, and if the patient is not happy with the visual outcome, you can always go ahead and do an anterior lamellar keratoplasty. However, if it's a dense scar like the photograph shown here, it is better to go ahead and do a combined procedure. Post-RK, these are very tricky eyes. The problem here is not just irregular astigmatism, but also the fear of the incisions gaping intraoperatively, and which can make things very, very stressful for the surgeon. So a Scheimpflug topography, again, to understand the irregular astigmatism, and an ASOCT to analyze all the incisions. Some of the incisions you don't know how deep they are and whether they're going to open up. So please do a detailed ASOCT and look at all the incisions, and if there is anything which looks precarious, please be careful, please be ready with sutures, glue, whatever is there as a standby. And as much as possible, don't touch the cornea, do preferably a limbal or a scleral tunnel incision. Side ports, I'd also recommend limbal incisions. Keep machine parameters low. As much as possible, do not touch the cornea, and please explain the patient preoperatively that your cornea is not normal, so do not expect miracles. Sometimes there could be a problem. So again, under promise and over deliver. Irregular astigmatism because of post-keratoplasty, first and foremost, remove all sutures, wait for 6 to 8 weeks for refractive stability. Again, Scheimpflug topography and an ASOCT. OCT helps in understanding whether the graft-host junction is secure, whether there is some area which is gaping, especially if the keratoplasty has been done somewhere else and you have no idea what was done. So you need to be very, very careful. Now, again, minimal irregular astigmatism, like the one which is shown here, one could go ahead and do toric, but very irregular, better to go for a monofocal topical IOL, and mini-scleral or a semi-scleral contact lens post-op. Again, this being keratoplasty, please warn the patient regarding possible rejection episodes, and you need to hike up the post-op steroids and gradually taper it so that you don't land up with rejection episodes. The third segment is ocular surface disease. I have divided this into 3 parts. These are the eyes with cicatrizing conjunctivitis, like the top pictures is eye with lead-Martin keratinization. This is Stevens-Johnson syndrome. And you can see the scar there. The lower picture, the right and the left eye, you can see the significant fornical shortening in the right eye, again signifying ocular cicatricial pemphigoid. These are very difficult cases. It is better you refer it to a ocular surface specialist for the cataract surgery. The second variety are those with the collagen vascular disease. They are most commonly being rheumatoid arthritis. They have the predominant dry eye is aqueous tear deficiency. The entire barrage of tests, starting with ocular surface disease index, test, T-BAT, etc. is absolutely mandatory. Detailed systemic workup and a rheumatologist consult is important. Amongst blood investigation, the CRP needs to be normal because it indicates a stable disease. Now, whatever immunosuppressives the patient is on, please continue that. And once the surface is stable and you're taking up the patient for surgery, we recommend a temporary punctal occlusion. You could use the collagen plugs which are there, which remain for about 3 months to tide up the surgical period. If it is not available, you can even use 4-0 catgut. Topical cyclosporin, again, something I really believe in, but use a good formulation which is in a good emulsion base. Take care of ocular surface intraoperatively. Make sure your staff doesn't keep on putting anesthetic drops because it roughens the surface. Do not induce epithelial defects, etc. intraoperatively because it becomes very difficult to treat these. Avoid postoperative NSAIDs and keep lubricating the surface intraoperatively. The third situation is possibly the most difficult ones, which are the ocular surface disease with the white inflammation, I call them. Most challenging cases because they often present with apparently very normal eye and just a cataract, and we think it's going to be a cakewalk. And typically 2 to 3 weeks post-op, they keep coming with the complaint, there is something in my eye, doctor, I don't know what has happened, what have you done during surgery. So so no matter how unassuming the patient is, each and every cataract, please ask for nature of work, screen time, any symptoms of ocular surface irritation, foreign body sensation, systemic disease, etc. The routine OSDI, pneumography, Sherman's test, and the T-BAT is absolutely important. One thing which we do in our clinic is we have sensitized the optometrists to do the IL-per calculations, to do the Scheimpflug topography. They don't get the Myers. They quickly put 1 drop of lubricant and take the reading. So sometimes those could be a red flag. You please sensitize your staff that if such things are there to inform you. So this could be an easy way to pick up these patients before they become a problem. Also, if those who have access to an epithelial mapping, an irregular epithelial map indicates probably an inflamed surface, and that needs to be treated before you take the patient up for surgery. These patients predominantly have MGD, or it could be combined, and rarely aqueous tear deficiency alone. This is what normally should be done. And for treatment wise, we have found very good results with the intense pulse light treatment. But having done this, wait for 2 to 3 weeks before you do the surgery. And again, we take all possible precautions. We treat the leads with oral antibiotics, lubricants, and even topical cyclosporin A. So with that, I'll summarize my talk. I hope I've finished on time. Thank you very much.
Thank you so much. Do you recommend clear corneal incision for your ocular cicatricial pemphigoid cases?
The dictum is that if the conjunctiva is abnormal, that is a cicatrizing conjunctival disease like ocular cicatricial pemphigoid and Stevens-Johnson, it is better to do a clear corneal. If it is a corneal pathologies like say PUK, etc., then sometimes we prefer to do a scleral tunnel. But in cicatrizing conjunctivitis, it is better to do a clear corneal. If visualization allows you, if there is scar, then maybe use a light pipe or a chandelier illumination to help you. And if nothing, nothing really works out, then maybe just do an extracapsular.
Thank you. Thank you, Dr. Sushmita, for highlighting the wonderful points for us.